Chelsea, are you finished your quiz?
Yes.
Okay, okay. All right, everybody. Oh, I'm sorry. We've got someone out yet. She's in breakout room. So let's wait a couple more minutes, okay?
I'm finished, Professor. I'm going to turn my camera for a little bit.
That's fine. We'll wait about 5 more minutes, okay? Hey, let me see here in the breakout rooms. Everybody who's here, please turn your camera on. I think we're ready to go. Okay. Somebody tell me what would you see on an electronic fetal monitor that would reassure you that the fetus is doing well during labor? In other words, what's the reassuring pattern that you would see? What would you
Accelerations is one of them.
accelerations? Yeah, we want to see the heart rate go up when the baby's moving, or maybe even during a contraction. Okay. What else?
I realize now I got it wrong, but I realize now after thinking back about it that the variation between 6 to 25 beats, I was reading it wrong. So I think that would be
Yeah,
okay.
so moderate variability would be another one. So we want to see changes in that fetal heart pattern as far as the rate, right? We want to see the heart rate go up at least 6 beats a minute throughout the time. So, and what about baseline heart rate? What should it be? Do you
110
remember?
to 160?
110 to 160. So a fetal heart rate of 110 to 160, some accelerations, and moderate variability. Those are the 3 things we'd want to see. Now we can see early decelerations. So what do I mean by early decelerations? When do they occur?
At the
When
beginning.
contractions?
Yeah, as the contraction is
Ends.
peaking. Yeah, so they mirror the contraction. So that's early. What's going on if during the contraction it begins to subside? Okay, so the contraction is beginning to go away, And then the fetal heart rate drops.
Late
What's that?
deceleration.
Late decelerations, why? What's occurring? What's wrong?
Less oxygen. Does it
Is
have
that
to
the placenta cord compression?
umbilical cord?
It's not
Late
the umbilical.
deceleration is the placenta perfusion.
Yeah. Yeah, late decelerations because the placenta is not reperfusing quickly enough. There's some kind of insufficiency going on there. Soon as that contraction begins to subside, we should see the placenta refill with blood very quickly. Okay, which in that case, if that occurs, then you're not going to see a fetal heart rate drop. Okay, so a late deceleration means that the placenta is not reperfusing. There's some kind of insufficiency there, poor blood flow. Okay, the 5 P's of labor. We've talked about this since week 3. So during labor, there are certain things that can inhibit labor progress and cause dystocia. Okay, so when you think of the 5 P's, we think of the passenger, the passageway, the powers, the position of mother, the psyche. Okay, so what about the passageway? That was on your quiz indirectly. So sometimes the passageway, the baby doesn't fit and it causes dystocia. If there's cephalopelvic disproportion, in other words, the structure and the size of the head does not fit through the mother's pelvic bone structure, okay? The inlets.
Professor, I had put BMI 19. I don't know if that was correct. No.
No, what's a high and a low BMI? You need to know your ranges.
Oh, it's
BMI
18.
19 is normal.
A BMI of 19 is good. It's ideal. So if you have an obese woman, 30 BMI of 30 or greater, then she's going to experience labor dystocia. She's at risk. Let me put it that way. She's at risk. Okay, so that's one of the risks, and that's part of today's topic. Okay, all right. There were some other things on there, but I don't want to go through anymore. All right, so let's do a question. Labor dystocia. Here we go. So the word dystocia just means something's causing difficulty. So there's a nurse caring for a client. She's a 31102. So she's had 3 pregnancies, 1 full-term delivery, 1 preterm delivery, and she has 2 children. So she's in labor now. She's in active labor. Okay. She has had a history, as you can see, of a preterm birth. She has used some illicit or harmful substances, alcohol, whatever, and she's developed gestational diabetes. She's doing well, and she reaches the 2nd stage of labor with her partner and the doula, the bedside. The midwife is there also, and she assists also with the birth. But she calls out shoulder dystocia. And then the nurse, the registered nurse, then calls for help. So what is shoulder dystocia?
Is that one that shoulders are unable to get past?
Yeah, so it's about the fetus, isn't it? And she is a gestational diabetic, so she probably has a big baby, especially if she didn't control her blood glucose during pregnancy and that baby grew. Okay, so usually we see shoulder dystocia in our diabetic clients. Okay, let me find the next slide. All right, so here's one of those NGN questions. Okay, so the patient's history of, and so number one is option one. And so look at the list below and look at the options. What history puts her at risk for shoulder dystocia during labor?
Gestational diabetes.
Yeah, you just said gestational diabetes is number one. Okay. Shoulder dystocia is an obstetric emergency. Okay. And the anterior shoulder of the fetus cannot pass under what?
Arch,
Cannot pass. I'm sorry, Mitchell, go ahead.
the pubic arch.
Yeah, the pubic arch. You know, the if you look at the structure of the pelvis, the pubic bone is like, it's shaped like this, okay? And so the arch is in the center, and that's where the baby, when the baby hyperextends the head in delivery, we can bring the head up, but then the shoulder doesn't follow, okay? And I've got pictures to show you. Okay, so pubic arch, all right? So signs of possible shoulder dystocia includes blank sign, in which the fetal head retracts against the perineum. It pops out, pops in, pops out,
Turtle.
pops in.
Turtle.
It's called the turtle sign. Yeah, the turtle sign. Good. So the instructions, the protocol, okay, and the nurse also receives an order from the provider, and that includes what maneuver?
Roberts.
Roberts,
McRoberts maneuver, yes. And what kind of pressure?
suprapubic,
Suprapubic.
Suprapubic pressure. So we do McRoberts is the flexion, Gaskin maneuver, flexion of the hips and the knees, drawing the legs way back. And when you do that, it actually opens up that pelvic cavity a little bit more. And then when we apply suprapubic pressure, and it's right above that pubic bone, the soft area, press down gently and in, that helps that shoulder, pushes that shoulder together a little more so it can pass under the pubic arch. Okay, good. That was just one concept. Okay, let's do one more. Umbilical cord prolapse. What would you see? What if you're the nurse in labor and delivery and you're suspecting prolapse umbilical cord? What are some clinical signs that you would see?
part of the umbilical cord sticking out of the vagina.
Yeah, you might actually visualize the umbilical cord.
And you could see variable decelerations in the in the whatever in the strip.
And the monitor, yes, very good, Adriana. Yeah, you would see variable decelerations. In fact, unless you were in the process of doing a vaginal exam, you're going to see it on the monitor first, right? Okay. What would you do? What is the very first thing you need to do?
Put the patient
Change the
knee,
position
chest
of the
position.
Knee
mother.
chest position.
Okay, change the position of the mother, the knee chest position. Or if you can't do that, you can do Trendelenburg.
Mhm.
I never remember how to spell that. Trendelenburg, I think that's right. What else would you want to do?
Need to put oxygen.
Push the baby inside. Bit moist.
Okay, we're going to push the baby or the presenting part,
Oh yeah.
not the cord. Don't you dare push that cord in. You're not doing anything. If you push that cord in there, you're making it worse. Okay. So we need to push that, whatever is presenting first. Okay. I know the cord, if the cord is right there and you see it, you're going to push on the head. Okay. We've got her up on her knees and her hands, and if we push on the head, it kind of pushes the head up away from the cord. Okay. So, and we're going to use a sterile glove, right?
Mhm.
Yes.
Push on presenting heart. Okay, I hear some background information. I mean, I hear some background noise. Has somebody got their TV or something on?
Oh,
Okay.
it's my husband in the background in his class. Sorry.
Okay, that's all right. All right, so yes, we're going to push with a sterile glove. Okay, and what else could we do? What else do we
Oxygen.
need?
Oxygen.
Okay, so this is teamwork, isn't it? This is where we get everybody in the room. Oxygen at 100%. How do we do that? How do we give her oxygen at 100%?
8
Flow.
to 10 liters per minute.
Mask.
Face mask.
Face mask, 8 to 10 liters. Non-rebreather.
Breather.
Yeah, we don't want to rebreathing our own air. Okay. What else do we need to do?
Use
IV
a sterile
fluids.
towel, moist sterile towel, and put it like on the cord to get it moist, to keep it moist.
Okay. What else?
Prepare the patient for a C-section.
Give IV fluids.
Prepare for a C-section, so we have to call provider, right?
Yes.
And anesthesia. Because if she doesn't have an epidural, we're going to have to do what? What kind of anesthesia would we have to do?
One that goes in
Epidural?
the
Just a shot into the CSF, right? You wouldn't want to do
The
it
shot
general.
into the CSF, that's one way, but epidural, we can't do that in an emergency. We're too busy getting her to the OR and getting her prepared for surgery. So what do we need to do?
General anesthesia.
General
I'm not sure.
anesthesia.
Okay.
Yeah, and is that what you meant, Adriana, when you say put the yeah, we have to intubate her and put her to sleep right away, quickly. So we give her gas. We gas her down very quickly, intubate her, and so we can get started. All right. Good. That was fun. Okay, let's talk about okay. When you take quizzes, you can do your quiz, on your computer, even if you have Zoom running on your computer. Zoom is not going to knock you off of your quiz. Okay. Just to let you know, Catrice, but that's okay. That's fine. All right. Let me find something else for us to do. We'll go through this PowerPoint and then we'll work on some there we go. Let's go there. So today we're talking about high risk situations, what can occur during labor and delivery that puts the client or her fetus at risk. So remember, during labor and delivery, we're monitoring both. Okay, we're helping mother with pain. We are monitoring the baby. What's going on with the baby? What are the contractions doing? Are they effective? Is she dilating? Okay, so we have to monitor all those things. Her vital signs. Is she developing a fever? Okay. Do you see foul colored or foul odor, amniotic fluid, or discolored? Okay. So we're going to talk about preterm labor and birth. premature rupture of the membranes, some infections, chorioamnionitis, and meconium in the amniotic fluid, post-term pregnancy, labor and birth. Precipitous labor, we'll review that, and dysfunctional labor, which we've talked about already, shoulder dystocia and prolapse cord. And then we'll talk about inducing labor. When do we need to induce labor? If our client is not in labor and we need to put her in labor, why? And how do we do that? And we get to review oxytocin calculation. And then we have some obstetric procedures that we have to use sometimes if there's some dystocia, and then some obstetric emergencies. Okay, so preterm labor are those labors, remember, that occur after 20 weeks and beyond. Okay, or not 20 weeks and beyond, 20 weeks to 36 weeks and 6 days. Okay, so if we have someone going into labor at that time, it's considered preterm. Okay, and remember that low birth weight is not necessarily a preterm baby. You could have an adolescent who's been pregnant and she goes into labor week 38 and she delivers a baby that weighs 2,200 grams. That's a low birth weight baby, very low. And yet it's not a preterm baby. Okay, so it's more concerning for that baby to be premature than low birth weight. Okay, in fact, prematurity is the #1 reason that newborns are admitted to the NICU, because they're prematurity. Intrauterine growth restriction is often a cause of prematurity. They were not allowed to fully develop, or at least to mature, and they're delivered too early. Intrauterine growth restriction also applies to low birth weight babies. Okay. So sometimes an indicated preterm birth, in other words, when is it indicated that we need to deliver a baby, even though it's before 37 weeks? Usually a maternal reason or a fetal reason. I'll give you one example. Is an adolescent maybe that has been experiencing, or at least her fetus has been experiencing, growth restriction, intrauterine growth restriction during the pregnancy, and she's 34 weeks pregnant, and that baby's still only at the 5th percentile. Not much growth, not much change. And she comes in again a week later just to survey. Remember, fetal surveillance. We need to keep an eye on that small baby and make sure that mother is aware of movement. So we have to reinforce being aware of fetal movement. If it slows down, then we're concerned. Okay, so we'll do another ultrasound, and maybe that baby's still at that 5th percentile. In other words, that baby's not growing, not thriving. And we don't want to lose that fetus. Okay, so we might go ahead and deliver that baby. If we can sustain it, we can for another week, and closely monitor. We might even keep her in the hospital. And we'll talk about that in a bit. So it's indicated that we deliver a preterm baby if the baby's at risk for mortality, or the mother is. Mother might have a deep vein thrombosis, or she might develop a pulmonary embolus before full term. Okay, or you have a diabetic that is just not strict with the glucose, and she's got a very large baby already at 36 weeks. We might go ahead and deliver that baby during that 36 weeks. And usually we'll do a C-section. And then there's most of the time it's a spontaneous preterm birth. Okay. Infections are usually the #1 cause of a spontaneous delivery before 37 weeks. Genital tract or intra-abdominal sexually transmitted diseases can cause a periodontal disease can cause preterm labor. There's some structural abnormalities. If a client has a didelphys uterus, in other words, a divided uterus with two parts, maybe it's like a heart-shaped uterus, and one side of the uterus is not functional, so the baby's grown in only half of a uterus, so they might deliver early. Okay. Wherever the placenta is planted, it might be abnormal implantation of the placenta, and they go into labor. Unexplained bleeding after the first trimester. We don't know why she's bleeding, and so we can often see those clients come in and deliver early. Stress, uterine overdistension, the progesterone, for some reason, the progesterone levels drop. Sometimes, of course, trauma will cause a woman to go into labor. Predicting labor, if you have a client that is leaking, we need to test that for amniotic fluid, but if she isn't, we can sometimes predict if she's going to go into labor by doing what's called a fetal fibronectin test. Fibronectin is a substance released by the fetus that lets us know that there is a possibility that she could be going into labor. But how we read, how we predict with a fetal fibronectin test is that if we do not find it, in other words, if we do a swab and there's no fetal fibronectin in the area, then we can say pretty surely that she will not be going into labor within the next 2 weeks. And that's how we read it. If we find the substance, it doesn't really tell us anything. So we're looking for a negative. Okay, we're hoping for the negative. Okay, and then the other cause is the shortened cervix. Sometimes that causes a woman to go into labor. If she has a cerclage on her cervix, if we banded it to prevent that cervix from opening up, then she's probably won't. Okay, we remove those around week 36 anyway. But if she has a cervix that begins to shorten later in her pregnancy and we didn't have an opportunity to band it and it's too late, it wouldn't really do any good, then she could go into labor. And so sometimes if we notice on an ultrasound that her cervix is too short, we can give her prophylactic progesterone in her vagina. Okay, we just have her put a tablet in every night. Okay, if there's a history of a shortened cervix or a cervix that tends to, we call it funnel. Okay, it dilates, the internal os dilates and it funnels down. Okay, we'll give her progesterone starting at about week 20, depends on the provider. So those are sometimes some causes of preterm labor and delivery. How do we manage these babies? If we know that a woman's having regular contractions, she's got low back pain, some signs of preterm labor or labor, early are pelvic pressure and low back pain, preterm labor. So if she's starting to experience that, we're going to get her in the hospital and monitor her for a while and her baby and we will try to stop the contractions by using a tocolytic. Okay. We also begin magnesium sulfate. Okay. If we're able to suppress the contractions, we might send her home and we might give her something like nifedipine, which is a calcium channel blocker for blood pressure, right? But it also relaxes smooth muscle. So sometimes if a client has a history of preterm labor, we might start her on nifedipine around week 20, 24, just so her uterus will relax. Indomethacin is another drug we can give. It's an anti-inflammatory, it's a suppressant, an anti-inflammatory type drug. We give it to rheumatoid clients as well, but we can only give it to our clients for a few days, and then we have to stop it. Same thing with NSAIDs. We don't want to give NSAIDs beyond 34 weeks during the pregnancy, because it will cause a premature closure of the ductus arteriosus. So we can use those drugs, but if it's obvious that she's going to be in labor and we're not able to stop it, then we have to consider the well-being of the fetus, all right? Our focus shifts. So what do we need to do for this fetus that's going to be delivered early? We know what the potential problems are. Immature lungs. If it's before 35 weeks, immature lungs. If it's before 34 weeks, then we can do something like give betamethasone. Okay, so betamethasone was one of your OB calculations. What we typically do is give her 12.5 milligrams intramuscular on one day, and then the next day, 24 hours later, we'll give her the second half of that vial, which is 12.5 milligrams. So she receives a total of 25 milligrams of betamethasone. So we're giving that to her for the baby, okay? Because betamethasone is a steroid and it helps stimulate increased surfactant production for the fetal lungs. Antibiotics for sure, because we usually know that most preterm labors, it's an infection going on, so we do need to start an antibiotic. We will also do a urine culture, a vaginal culture, just to see if we can identify any microorganism. And then why are we giving magnesium sulfate?
To prevent seizures.
It prevents issues, yeah. So we're giving it to protect the cerebral arteries of the fetus. Okay. When we have preeclampsia, we give this as well, right? For mother's brain. Okay. When we give it for mother's brain, the fetus benefits from it as well. Okay. So for preterm labor, even though mother's not having preeclampsia, we want to give it for the fetal brain. Okay, so what it does, remember, it improves the circulation of those cerebral arteries, which helps prevent cerebral palsy and some kind of cognitive damage or neural damage. Okay, so that's how we manage. That's what we call expectant management of preterm birth. We know the risk associated with it. We know what potentially causes it. So we know the baby's lungs are not mature. So there's 3 things that we must do as part of our care plan. Steroid for mother, antibiotics, magnesium sulfate. If we have a client that calls the office or shows up in the ER saying her amniotic fluid is leaking, and yet when we put monitors on her and she says she's not having any contractions, she's experienced premature rupture of the membranes. Okay, so she's leaking amniotic fluid even though she's not in labor. If she doesn't go into labor within that hour, then it is called premature rupture. If they rupture and then she does go into labor within the hour, then it's not really a premature rupture. Okay. Amniotic fluid is vital for the fetus, for movement, for protection, buffering, maintain temperature. And if it begins to leak, that means that mucus plug or the endocervical operculum, the mucus that's in the endocervical cervical canal, protecting the fetus and the amniotic fluid from bacteria that's in the vaginal or urinary tract. Once that plug is released and she begins to leak fluid, then bacteria can actually migrate vertically into the amniotic fluid and to the fetus. So an outcome of premature rupture of membranes, if we don't know it's occurring, is infection. Okay. The most common one is called chorioamnionitis. Okay, chorio is the inner membrane of the amnion, or the outer membrane of the amniotic fluid, and then the amnion is the inner lining. So the amniotic membranes are really two membranes that are really they're very close together. Okay, and both of those get infected. So it's called chorioamnionitis. Okay, so early rupture of amniotic fluid and not going into labor, that fluid is a great medium for bacteria. Okay. Sometimes preterm labor can lead to placental abruption. Okay. A retained placenta with premature rupture of membranes, she goes into labor and she has that infection that's in that amniotic sac does not allow that placenta to fully pull away. Okay, hemorrhage. And then if we don't adequately treat the chorioamnionitis, if our antibiotic that we choose does not destroy the bacteria, then that infection can actually spread to the uterine lining. Okay, and it's called endometritis. Endometritis, not endometriosis, but endometritis. And then cord prolapse. So these are some of the possible outcomes from a premature rupture. So premature rupture, less than 34 weeks. If what we would do is if we do an ultrasound. Oops, where'd that come from? Stop that. Okay. We would do an ultrasound, and we need to make sure mom understands that she needs to be aware of baby kicking. Okay. We also need to be aware of, I don't know why that's doing that. Premature, this is a premature rupture of the membranes. If we have preterm premature rupture, okay, so our baby's preterm and the fluids are leaking, okay. If there's no sign of infection, we want to postpone delivery as long as possible, okay. So we do the expectant management. We might do assessing pulmonary maturity, but we don't do that much because that further increases the risk for infection. We might do some non-stress tests, watch the mother's temperature, observe temperature, and then go ahead and administer antibiotics and magnesium sulfate in the hospital. So chorioamnionitis, here's a picture of potential areas of invasion. So there could be, mother could have an infection in her blood. She could have some bacteremia, okay? Placenta could actually have bacteria pass through it. The uterus could be infected for whatever reason, and that invades the amniotic fluid. If we do an amniocentesis late in pregnancy, there's an increased risk of infection. And then the last one would be vertical transmission, in other words, coming from the vagina. So those are the routes that bacteria can invade the amniotic fluid. You're thinking, what do you mean they invade through the skin? Yeah, it can invade actually through the skin. The abdominal wall could have an infection that invades the uterus. So some signs of clinical signs of an infection of the uterus are fever and tachycardia. So a temperature above 101 or 101 and higher. Okay. Uterine tenderness and foul smelling purulent amniotic fluid. if we don't treat it, mother could actually have dystocia during labor and develop the endometritis we talked about. The fetus can develop pneumonia and or meningitis. One of the most common bacteria that can cause chorioamnionitis is E. coli and group beta strep. Remember, we talked about group beta strep early on. It is an organism that some people just carry. It's on their skin or it's in their tissues, like in their vagina or their rectum or their urethra. And it doesn't mean there's a urinary tract infection, and we don't normally treat it. But in pregnancy, we do. So if we do urine culture at the beginning of pregnancy and we find group beta strep in it, we know ahead of time when she goes into labor, we need to start treating her right away, even if she doesn't have a fever. Even if there are no signs of infection, we're going to treat prophylactically with penicillin if she's not allergic to it. Okay. So any time that we have a client that has an infection, we are not going to stop her from, if she develops preterm labor, we're not going to stop the labor. We're not going to try to stop the labor because of the infection. Okay, we can't treat the infection. We're putting the fetus at risk. So we can't, it's contraindicated to use tocolytics with the client with a fever. Post-term pregnancy. Any pregnancy beyond 42 weeks. 42 weeks and beyond is considered post-term. The placenta basically the placenta is old. It's a temporary organ. It's beginning to lose its efficiency. It actually will have calcium deposits on it, which means that that portion of the placenta is not going to provide exchange. Okay. Some risk associated with late delivery, post-term pregnancy is labor dystocia, dysfunctional labor, injury from a large baby, hemorrhage, fatigue, needing a C-section. Babies are large. They can be injured easily if they're too large. Cord compression because the amniotic fluid begins to drop off. So that's called oligohydramnios. Oligo means a small amount. Oliguria means small amount of urine. So oligohydramnios means small amount of amniotic fluid. And that's what happens after that 40th week. The amount of amniotic fluid begins to drop off. And so now umbilical cord compression is a risk, as well as infections. So these are your post-term pregnancies.
How long would they let mom go after 40 weeks before they would go in and do a C-section if nothing was happening?
Well, that is a really good question, Mitchell, and nobody from the first earlier in the week has asked me that question. It is a great question. And evidence-based says these babies need to be delivered. If they reach 42 weeks, they need to be delivered. Increased incidence of C-sections, infections, mortality rate goes up, and all the things we talked about. Hopefully, and every provider might have a different philosophy. And if that provider is not aware of what's going on in the evidence actually says that week 39 is the most ideal week to deliver a baby, because before that you might have problems, and after that you might have problems. So week 39, if a client is scheduled for a cesarean section, it's going to be during week 39, because that's the week that it's called the golden week in deliveries. Okay, does that answer your question?
Yes,
So
ma'am.
are you at the mercy of your physician when it comes to delivering after 39 weeks?
In other words, if you don't want to deliver, you want to wait?
Or no, if you want to deliver, but your physician says, no, we're going to wait till at least 42 weeks. if you're past your
I'm not-
39-week mark?
I would get in, so this is something that you would hopefully have a discussion about before you got to that 39th week. Because if you don't want to go beyond 39 weeks and your provider won't, then you need to switch providers. Yeah, yeah. And I don't know of you know, and I'm not saying I know more than a dozen providers, so that's a really good question. But by law, I suppose, I mean, by choice, you can get to another provider. But most women want to deliver, okay? And as far as I know, most providers recognize that, and they like planning and induction because it's more convenient for them. They don't get called in the middle of the night. The one provider that I worked with, he wanted to schedule everybody for an induction. If they don't go into labor by the 38th week, he said, "Hey, you want to induce this baby next week?" Offered it because you have control. So it would, and it worked very easily. Good question. So this PowerPoint goes over all the different causes or etiology of possible dysfunctional labor. And we've talked about some of it, but I want to bring up, other than the anatomy of the mother, the size of the baby, and that sort of thing, ineffective uterine contractions, but maternal, remember when our client gets anxious, the uterus will not contract effectively. Anxiety increases catecholamines in the system. Okay. An older woman, epidural anesthesia, even though it's not a uterine relaxant, it does tend to slow labor down just a little bit, but it's well worth it if mom needs that pain relief. Okay. And then obesity. Okay. Other things might be multiple sclerosis or myasthenia gravis. Any kind of neuromuscular disease might slow down labor. Okay. Your book goes into a lot of other descriptions of dystocia, like protracted labor and all those, the terms. And you don't need to know all of those. Okay. If we have a client that's in labor, maybe early labor, or wants to deliver vaginally and she's not in labor, and her baby, and she's in week 39, and we plan to induce her, and we find that her baby is not head down, is not in the cephalic position, we can do what's called an external conversion, okay, or version. We can just call them versions. In order to do this, there's certain criteria. Number one, she needs to have a non-stress test first, making sure last minute we do an ultrasound right before the procedure, and then giving her a tocolytic, something to relax the uterus. Okay. During the procedure, we're going to monitor, of course, the fetus. Okay. If she's Rh negative, we're going to give her RhoGAM. Okay, we're going to go ahead and give her some RhoGAM, because during version, if there is some mixing of blood or some emergency comes up, she'll be protected. Okay, so that's just what we call version. Sometimes it's not a complete breach, and we just need to manipulate the baby a little bit to bring that head down. Precipitous labor, remember, any labor that begins and ends within 3 hours is a high-risk situation. I had a client that delivered 4 babies that way. Bam, she was done. She would come into the office. I remember her second baby when she came in, and she was 36 weeks along, and we begin to check the cervix for dilation. And I checked hers the week before because I knew she always delivered early. And she delivered around 37 weeks and it went quickly. Well, she came in at 36 weeks and she was 4 centimeters dilated. And she wasn't having contractions, but she was dilated and she was thinning very quickly. So she said, I know. She said, I know if I start having contractions, I'll be there. And she just delivered so quickly, but she never really had any problems with it. But there are risks associated with that. Uterine rupture because contractions are so happening so quickly. Sorry.
Are they like stronger contractions that way, or are they just closer together?
They're stronger and not necessarily closer together, but they're just effective. They're just very effective. And for some reason, it just happens quickly. We don't always know why. We don't want any, what word am I looking for? Uterine tachysystole. We don't want contractions to occur more than 5 and 10 minutes. But a precipitous labor, we need to stop. We're certainly not going to be given oxytocin. Okay. So if she goes quickly, we just have to, and we're not giving oxytocin, there's not much we can do. We don't really want to give her a tocolytic because we don't want to stop it. So we monitor the baby to make sure the baby is tolerating labor. Okay. So we're going to, complications, possible hypoxia because of the quick transfer or the quick descent. Okay. Intracranial trauma. It's not a slow movement. Okay. Uterine rupture, lacerations to mother, amniotic fluid embolus, postpartum hemorrhage. And of course, if she is having hypertonic, in other words, stronger contractions than what we like to see, or uterine tachysystole, if we don't stop it, it can actually cause a placenta abruption prematurely. And then we usually see cocaine use with that. And the fetus says, wow, what's going on? So we're going to have to induce our client into labor because she is 30, let's say she's 41 weeks and she's not in labor. So we've decided she didn't want to go any earlier, so we need to get it done. So she agrees and we do an assessment to see where she is as far as her cervix. So we use our Bishop score. Okay, so we're going to look at all the criteria. We're going to look at well, actually we do a palpation. Where is the fetus? What's the fetal station? Where is the fetal head? Is the head engaged? What station is the fetus? Is the cervix soft or is it firm? Is it effacing? Is it shortening up and thinning out? Is it dilating? So we mark our scale and come up with a 6 or 7. Good, she's good to go. Let's start some oxytocin. Okay, but if it's less than 6 or 7, now there's no set number. You're not going to be asked about a set number unless it's really low, like 4 or 5. Okay, so let's say she's not, her cervix is still pretty firm and it's only dilated to a 4 or a 3. Okay, and effacement is only 50% maybe. So let's say the Bishop score is too low. We're going to have to prepare the cervix. We're going to have to soften it. We're going to have to give something to the client to help that cervix go ahead and dilate and efface before we start labor. Okay, and what we use are the prostaglandins. Okay, we put a tablet around the cervix, actually behind it. And some of the tablets are removable, which is nice. The dinoprostone is a removable tablet. It's an insert. Or we can use prostaglandin gel. to apply to the cervix, and it actually will help it to soften and begin to dilate and efface. And we'll do that, every few hours until we get that cervix where we need it to be, bishop-wise at a 6, 7, or 8. Once we're there, then we can start oxytocin to start contractions. We can't start unless the cervix is ripened enough. We call it ripening. If we don't do that, then labor will take forever for that cervix to dilate. So we can really enhance labor progress by preparing the cervix. So remember, oxytocin is a natural hormone. We give it exogenously, Pitocin or oxytocin. It's a high alert drug. It causes uterine contractions, and it causes breast milk or colostrum ejection. Okay. So, of course, adverse effects of this, if we give too strong of a dose or we give it too rapidly, and causes tachysystole and rupture, abruption. And of course, fetal hypoxia, hypoxia, infection. We use oxytocin to induce labor. We use oxytocin in someone who went into labor spontaneously to make the contractions more efficient, effective. Okay, so we use it for augmentation. And then we'll use a high dose of oxytocin postpartum to help contractions, to strengthen the contractions so that the uterus will stop bleeding. So this is a bag of 1,000, I think, 100 ml. It is 500 ml bag with 30 units or 30,000 milliunits of oxytocin in it. So remember, if we're using it, whatever reason we're using it for, it's always a good idea to double check your rate of your pump with another nurse, especially if you're going into this field and you're new. Just have someone else, and it might be a protocol in certain facilities, so you need to know that. So if we order 2 milliunits a minute, or if the provider orders 2 milliunits a minute of this solution, so 20,000, this is one of your questions on in your OB calculations. So 20,000 milliunits in a liter, okay? And you can see how I converted that and broke it down to 20 milliunits in 1 ml. Okay. Now that we know that, we can set up a proportion that we want 2 milliunits. So I put 2 milliunits over 20 milliunits, and then X over 1 ml. And I came up with, we need to give 0.1 ml every minute for her to get those 2 milliunits every minute. And then I just multiplied it times 60, because there's 60 minutes in an hour. So we know how many mLs in an hour she needs to give her 2 milliunits a minute. And that is 6 mLs an hour. So that's how I do it. Now, this isn't dimensional analysis. If you do your conversions with dimensional analysis, you set it up a little differently. Okay, this is just another thing that you can look at. Vacuum assisted delivery is an obstetric procedure. It's like the cephalic version. Okay, so vacuum assisted delivery, sometimes we just need to give support when that baby's head might be just a little larger, or mother's having trouble pushing. We need to assist. We can apply vacuum negative pressure on the baby. It's kind of reasonable that the amniotic membrane sac needs to be broken. If the sac's not broken yet, you can't do this. If she's not fully dilated, can't do this, or fully effaced, you can't do this. Okay. We know for sure that the head is going to fit through the structures, so there's no CPD. Okay, no risk of CPD. And of course, vertex presentation. In other words, what is presenting through the vagina is the vertex of the head and not the face. Okay, so you can imagine injuries to mother and baby with this, using this. One is mother could develop hematomas from damage to the soft tissues or lacerations. The fetus also could develop a cephalohematoma, or even a kaput, which we talk about during newborn. Subdural hematoma, scalp lacerations, which lead to jaundice. Okay, let's take a break. Okay, 25 after, 26 after, let's say 40, 340, 440, wherever you are in the world, whatever time zone you live in.
Can you leave it on the slide where the bishop score chart is?
Oh, sure.
Thanks.
How's that? Whoops. Oh, let me just do this. Is that what you want to see?
Yeah, thank you.
You're welcome. Well, that didn't help much. I'm just messing it all up.
Where is that dystocia?
I did want to let you know that the original PowerPoint I put up for this week, labor complications, was changed. I changed it to the one that I've been going through today. So if you downloaded the original, it's not the same as the one we're doing right now. For some reason, I lost this PowerPoint. It was in the murky depths of my computer or somewhere floating around in the cloud. I don't know. All right, let me, this two here. Okay. So another way that we can assist labor and delivery, I should say, is the instrument we call the forceps. Forceps is something that grabs, okay? So these forceps are considered locking. So we apply them right here. As you can see where the mark is on the newborn, we apply them around the baby's head. Then we lock it so that as we apply pull on those forceps, we're not squeezing any tighter, okay? So you can imagine, and there's a picture down here, and I don't think we do this in the States, but a breech delivery. They use forceps in this breech delivery. But we usually don't do that in this country. As far as I know, the consequences of having to use forceps is a lot more serious. Lacerations are more common, and damage to the maternal bladder or urinary retention, hematoma, scar tissues, scars and adhesions and stuff like that. I think I need to shrink this down a little bit. Yeah, there we go. And then the you saw the picture here where it actually left a mark on the baby's face and some bruising. That's just some potential outcomes. Facial palsy is another one. A palsy is a term that refers to paralysis, okay, or lack of movement. Sometimes, the facial nerve travels down this direction, and if we use forceps, it could compress on that facial nerve and cause palsy. Like you're familiar with a Bell's palsy, facial paralysis on one side, and it's usually temporary. So if you have a client that had forceps used and her baby has a little facial palsy, you can try to encourage her and tell her it's temporary and it will resolve. Sometimes it might take a few months, but it will resolve. But that's just a consequence of forceps delivery. So if we have, you know, just prolonged and baby's not descending, even with pushing, we might have to use forceps. Sometimes we'll use forceps if we just need to turn the baby a little bit more so we can get that baby under the pubic arch. There's a term called VBAC and TOL. VBAC means vaginal birth after a C-section or a cesarean surgery, and trial of labor, TOL. If a client delivers their very first baby via C-section and had what's called a classical scar, which is the one in the center here. There's probably a picture in your book too. Vertical incision in the uterus, not the stomach, not the abdominal muscles, but the uterus itself. That means that that uterine muscle was, you know, open. And so it's got a huge scar there in the middle. So if we were to allow her to go into labor, you know, there's an increased risk for rupture where that scar tissue is, because that scar tissue is not going to stretch. So we don't want her to go into labor with the following pregnancy. So in her second labor or second baby, she has to have another C-section. Okay, we can't let her go into labor and deliver vaginally if she had that classical incision. Okay, but if she didn't, if she had a low line horizontal incision on her uterus or low vertical, then we can let her go into labor. But she has to go in on her own. We can't induce labor. Okay, so that's what we mean by trial of labor. We'll let her go into labor on her own. Okay, and if she's progressing nicely, we can just let her labor down and deliver. But if she doesn't progress at that 1 to 2 centimeters every hour dilation, then we're going to have to do a C-section. It's also recommended that if she delivers by C-section, that she really needs to wait another year before she even gets pregnant. And that's always recommended. It takes time to get over a C-section. Wait until her body systems build up the reserves again, and that tissue has had plenty of time to heal. A year is not unusual. If she's going into labor spontaneous after a C-section, the baby has to be in the cephalic position. Okay. I don't think we would want to do a version on someone that had a C-section. Okay. So when we do cesarean sections or cesarean surgeries or C-sections or CS, however you want to say it, cesareans, we either do them electively or we have to do them emergently, right? And we talked about emergently doing a C-section if baby has umbilical cord prolapse or some other emergency comes up, placental abruption. So some concerns also is that if there's a cardiac history, if her heart is not going to be able to tolerate labor, we have to weigh the benefits with the risk. It might be more beneficial if we help her through labor with an epidural, control her blood pressure, okay, and her heart rate, so that her heart isn't working too hard. Because to do a C-section would put her at a greater risk for blood clots, right? So that would make it even worse for the heart. Aortic stenosis, that lower part of the aorta that's very narrow, so that the heart really has to work hard to pump the volume. Okay, Marfan syndrome, same thing. Okay, coronary artery disease, all three of those. So for a surgery, for any surgery, and for a C-section, you consider it a major surgery. Okay, informed written consent. Okay, the anesthesia person has to get permission to provide analgesia and anesthesia. And the obstetrician who's delivering the baby doing the procedure we have to give permission, written permission for that as well. We have to type and cross for blood, at least type and screen, okay? We might do other sets of labs, do an ultrasound. And then as a nurse, you need to make sure those things are on the chart before she goes to surgery. Okay, make sure she understands what's going on. If she has questions about the surgery, then she needs to talk to the provider again, okay, or the anesthesia person. You need to go ahead and put sequential compression devices on her legs, SCDs we call them. So those are going to massage her legs alternately, sequentially during labor and during recovery and until she's up and running or up and ambulatory. And then a Foley catheter, because you need to know if her urine is nice and clear and the bladder's not been nicked or something. You need to be, she needs to be on I&O, and we need to know blood loss. Okay. We could do C-section with spinal, okay, anesthesia too. And of course, if it's emergency, we do general anesthesia. So general anesthesia, they need to go through recovery after the procedure for at least an hour. So this kind of inhibits that bonding time, skin to skin with mom right away for general anesthesia. And, you know, she's going to be sedated for a while. So we have to consider the risk to the baby. If we leave her alone with the baby when she's sedated, as a nurse, you know, you would be liable if something happened to the baby. So we can't really leave her alone until she's fully alert. As with any surgery, the risk associated with it, infection, injury to adjacent organs like the colon or the bladder, the ureters, blood clots, deep vein or pulmonary embolus, fetal asphyxia and respiratory distress, fetal respiratory distress, hemorrhaging, blood loss. When a baby's delivered through the vaginal canal, the lungs are squeezed slowly, so a lot of the excess, run out loud, all the excess fluid during a vaginal delivery in the lungs is slowly released. Whereas during a C-section, the baby doesn't go through that. So there's a little more transient tachypnea, maybe a little more respiratory distress with our C-section babies. I think it'd be cute to write a comic on babies being born, you know. What the heck happened? Meconium is also an emergency. Okay. During labor, if baby has a lot of late decelerations or umbilical cord prolapse, anything that reduces the amount of oxygen that the baby gets during labor actually accumulates. So the baby could become hypoxic during labor. And hypoxia leads to vagal stimulation, the vagus nerve, which reduces heart rate. Okay, and that vagal stimulation also causes meconium to be released from the rectum. Okay, in other words, baby poops in utero because of hypoxia. And so they're born with meconium all over them. Meconium is considered the very first bowel movement of a newborn. So if you can imagine, they're covered in this stuff. And you know that meconium is what they're swallowing in utero. Okay. So if they develop hypoxia and they release a stool, all of that's going to easily be aspirated after they're born or just before they're born. So it leads to meconium aspiration syndrome, which is really hard to manage. because it's not necessarily an infection, it's inflammation of the lungs. Okay, so pneumonitis. So if you were working in labor and delivery and you noticed that the meconium was becoming discolored in more of a green tint to it, what would you do? If you saw green amniotic fluid, what would you do?
I'd notify the physician.
Yeah, you notify the provider. Who else do you think you want to help with the situation? Because we're worried after delivery, right? What else who else do you need to notify?
Respiratory?
Yes, respiratory support. You need those high risk nurses, okay, neonatologists, NICU nurses, in other words. You need all those people on board to manage respiratory status in the newborn. Okay. Okay, here we are, shoulder dystocia with the turtle sign. Okay. Think diabetic. Okay, when you think about shoulder dystocia, think diabetics, whether it's type 1, type 2, or gestational, because they have the large babies and the broad shoulders. It's not only the baby's large, their shoulders are broad, their trunk is bigger. Okay, so they're a little out of proportion. Okay, so the anterior shoulder, and you can see it in this picture, anterior means the top, because when we look at the vagina, the top is considered anterior and the bottom of back wall of the vagina is considered posterior. So you see the anterior shoulder there is kind of pushing up against that pubic bone. Okay. And so fetal asphyxia, of course, fractured of the clavicles. So the clavicles are here, right? And if your shoulders are broad and you're pushing and you're trying to get that baby born, and baby's on the side at that point, getting ready to rotate internally or externally, I'm sorry. And if you're applying pressure on that anterior shoulder, it pushes those shoulders together, and the clavicle on that side is going to be broken, could be broken. So a clavicle fracture is very common with the shoulder dystocia. Also, it could be a humeral fracture, that bone in that arm. Okay. And then also, if you notice, maybe not in this picture, but the hand that's supporting the head, because you're pushing down, you're pulling up on the head a little bit, you could actually damage the brachial plexus, these nerves here. So we intervene by doing the McRoberts maneuver. And here's another picture. There's pictures in your book too. Here's another picture of the McRoberts maneuver and Gaskin maneuver, the suprapubic pressure, and then the support of the fetus. The hips and the legs are as flexed as we possibly can get, and that opens up that pelvic structure a little bit. And umbilical cord prolapse we talked about. Now this picture is cut off, I realize that. But you can see this baby's in a breech position, so it's a greater chance of that cord dropping down. So if you were to get mom up on her hands and knees, those feet would fall back down and relieve the pressure on the cord. Same thing with the other picture. You can see the cord there. Right there. It's pinched against the cervix and between the fetal head and the cervix. So if we get mom up, that baby is going to pull back. And so you want to push on the head get it away from the cord so that blood can flow. This just describes the umbilical cord. So make sure you stay with your patient, call for help, reposition. Okay, get her up on her knees and on her chest. And with a sterile glove, go ahead and push on the presenting part. A moist, sterile towel, which are usually available close by. Oxygen, 100%, IV fluids. Monitor the fetus, of course, and prepare for a C-section. Here's the knee chest position. So once again, what would you see on the monitor if the cord was prolapsed?
Variable deceleration.
Variable decelerations, yes. And here they are. See, this isn't a very good picture, but this is, it shows a deceleration, and it seems everything seems to be okay. This is a uterine rupture. And then all of a sudden the baby's heart rate drops down and it becomes prolonged deceleration. So this is uterine rupture, extremely rare. Okay. A previous uterine scar is torn.
Does the mother get a hysterectomy after that?
Oh yeah, yeah. We're trying to save her life, and one way of doing that is to clamp off those uterine large vessels, uterine arteries. Yeah, you have to do a C-section or a hysterectomy. And then the last one is embolism. So amniotic fluid versus blood. Okay, amniotic fluid, and this occurs sometimes after an abruption, placental abruption. Okay, it's also called anaphylactoid syndrome of pregnancy. It can occur a few minutes after delivery. So, as with a pulmonary embolus, anything that's blocking, any embolus or an object that's floating in the circulation is going to block off eventually the pulmonary artery, because that's where the blood enters, the heart into the right atrium, right ventricle, pulmonary artery to go to the lungs. So the lungs are blocked off, or at least a major portion of them are, and they can't breathe. So it's an emergency. Sudden respiratory distress, dyspnea, sudden respiratory distress, cardiovascular collapse, coagulopathy, which is clotting everywhere like DIC, acute hypotension, obviously, hypoxia, potential causes, meconium stain amniotic fluid. So if the meconium has also been included in the amniotic fluid. Uterine tears, precipitous labor, cesarean section, abruption, placenta previa. We usually do a C-section. We do a C-section, not usually. We do cesarean sections for previas because we can't deliver vaginally. So usually the facility has a policy. How long do you do CPR before you try to save the baby? And you're trying to save the mother. And as long as the mother is doing well, the baby should be doing well. But if she's not, if you're trying to resuscitate her and you can't get her oxygen level up and it's not going well, then after 4 minutes, you need to do a C-section. Okay, CPR for 4 minutes. And then we do, you're not going to be tested on that. Okay. All right, so that's exciting.
Will you send us the new PowerPoint? That new PowerPoint?
It's already in the
Oh, okay.
announcement. Yeah, it's in the announcements for week 6. If you can't find it, let me know. I'll get it for you. Certainly. Okay. Any questions about any of that? I did a lot of talking, and we have about 30 minutes left, almost, not quite. So I'm going to send you into breakout rooms, and what I want you to do, let's see, pull up. What do I have? A concept map. Do y'all have a copy of the concept map somewhere that I gave to you? Yes? No? All right. You need to learn how to do this. To me, it makes it kind of makes sense to me, like Nicole will mention, concise, organized, that sort of thing.
I'm
I
not a
think that's what
concept map fan, so wasn't talking about
you're
that.
not.
No,
Oh,
I'm not.
why not? What is it about the concept map you don't like?
It just doesn't work for my brain.
Oh, it doesn't work for your brain. Oh, dear.
No, it doesn't. But I still do them. If like
Yeah. Yeah. Maybe it would if you did enough of them.
okay.
But I don't know. I don't know. You just, yeah, I don't know. Okay, so here is a concept map. So we put the concept in the middle. So like preeclampsia, what are some risk factors for preeclampsia? In other words, what clients are at risk? What are some signs and symptoms?
Is
for
this one that you sent us?
This is a template, yeah.
Okay.
I might have sent you, there's different kinds, but it's the same idea that you put the concept in the middle. You think about the risk factors and what you would see as a nurse if you suspected the concept is occurring. What kind of labs and diagnostics would reinforce your suspicion? And then possible etiology, pathophysiology, if you're interested in that. Medications, how do you treat it? And then potential complications with preeclampsia, nursing client education. And then for preeclampsia, we give magnesium sulfate. So how do you evaluate how it's working? So you could do preeclampsia, you could do, let's see, what concept did we talk about today? Meconium aspiration or preterm birth. It could be your concept. And so risk factors, okay? What are some signs and symptoms of preterm labor? How do you know she's in labor? Or what are some diagnostics? Etiology, treatment, medication. What's our expectant management? Okay. Complications, which you wouldn't be able to answer yet until we go to high risk newborn and we talk about complications of a preemie. Okay. What are your interventions in your education? Okay. So you might not be able to fill up all of the squares. Okay, but you can work on them with the list of concepts that I gave you. So what you can do, oops, is get rid of this. Take a picture of it with your phone if you don't have a copy of it somewhere, or do a screenshot, and let's break up into groups. And I don't care which concept you use. Let me find let me stop sharing because I don't want you to. Okay, let's see. See here. You can do labor complications, something occurring during labor. You can do postpartum assessment. You can do postpartum hemorrhage. Put that in the middle. Preeclampsia, abrupted placenta. Put that in the middle. What are some signs and symptoms? How do you treat it? You could put preterm birth, like I said. So you can use any of those concepts in the middle. And I'm just going to let you choose which one you want to do, or you want me to assign you one. And work on it as a team, okay? What do you want to do first? You want me to choose a concept and everybody work on the same one? Yes?
Yes.
Yeah.
Yeah, that would be
Okay.
good to hear what everyone else did, see if we missed anything.
Okay, let's do this one. Let's do hyperglycemia in pregnancy. Okay, or type 1, type 2 diabetic, or gestational diabetes in the center. So what you're doing is you're looking at the risk factors associated. Signs and symptoms of hyperglycemia. What kind of labs do we need for a diabetic? How do we monitor hyperglycemia? Of course, you're not going to etiology and pathophys. You don't need to do that one. Medications and treatments. Potential complications. There's a lot here for diabetes. Okay. Do as much as you can. You're not going to be able to do it all. Any questions? Hyperglycemia in pregnancy. Am I sure? No, I'm not. Okay. Let's see. We only have a few minutes. I'm going to go ahead and put you into breakout rooms, and so we're working on hyperglycemia and pregnancy. So this is information from last week. Okay. Recreate 6 automatically. So I'll give you 15 minutes, okay? 10 minutes. Just do what you can. We're running out of time, really. Patrice, where are you? Patrice, are you there? Oops. Patrice, what you doing? You having trouble with your internet? Did you get knocked off?
Yeah.
Yep. You can go back to room 1. I think you were in room 1. And there you go. You can join now.
Hi, Professor.
Okay. Good deal. That was quite a challenge for you. Okay, so there's Janique. She's almost upside down.
I
It's all
know,
right.
right? I was wondering.
Okay, so pre-gestational diabetes or gestational diabetes, a risk. Okay, so what did you come up with for your outcomes?
We have age,
Okay, so risk factors. Okay, age.
family history of diabetes,
BMI,
Obesity.
hypertension,
Race.
obesity,
Overweight, obesity.
Okay, okay. So we have our client now. Tell me, let me pull up my map. What are some signs of hyperglycemia?
Increased thirst.
blurred vision, dry
Fatigue.
mouth,
Acid
A
on
fasting
breath.
glucose higher than 100.
Okay,
all of your
higher than-
polys, polydipsia, polyphagia, polyuria.
Pretty
Mhm.
breath.
good.
Yeah.
Yes, good. Good deal. Good. Now, what are some outcomes, possible complications of hyperglycemia during the first trimester of the pregnancy? Do you know?
Neonatal hypoglycemia.
During the first trimester.
Spontaneous abortion.
I know insulin needs to be reduced during the first trimester.
Okay. But if she's hyperglycemic in the first trimester,
Spontaneous abortion and congenital defects.
there it is on the screen. Yeah. So if we have a client that is a type 1 or type 2 diabetic and they are hyperglycemic in that first trimester, we're going to be concerned about congenital anomalies. Okay. And so some other outcomes of hyperglycemia is in the second trimester. So continued hyperglycemia. You talked about polydipsia, right? Polyuria. Well, the fetus is doing the same thing. Growing, lots of fluid. She's at risk during pregnancy for stillbirth. Okay, a baby that dies before delivery, and for preeclampsia. And somebody mentioned gestational hypertension. So gestational hypertension is a side effect or could be even just obesity. Okay. And you can see with the conversation that you had how obesity and hyperglycemia overlap. Okay. So she's at risk for a lot of problems. And then during labor and delivery, potential outcomes. Okay. Labor dysfunction, shoulder dystocia.
Yes, shoulder dystocia.
Yeah, having to use forceps or vacuum assisted birth, C-section, injury to mother and or baby, infection, DVTs, and it goes on. And when we talk about the newborn, next week, week 7, we begin with the normal newborn. And then we'll be talking about those newborns born to a diabetic mother. What are some things that you would see? Respiratory distress and hypoglycemia. Okay. So thank you so much for at least trying and working on it a little bit. I know it's not easy to do concept maps, especially with diabetes when it's so complex. And Nicole is probably pulling her hair out by now. Where is Nicole?
It was actually pretty good, Professor.
Was it? Did
Yeah.
it work out okay for you, Nicole, or not?
Yeah, it was all right.
It was okay. So
I still
maybe
like them.
looking, yeah. So maybe looking at it on a time frame would be better. But okay. But thank you anyway. So You could still use that concept map. You can simplify it if you want to, whatever helps you understand the concept. Okay, so you want in particular to know the signs and symptoms. Okay, and you want to know the outcomes and the interventions in particular. Okay. All right. So I forget I was going to say something. Oh, I was going to talk about the teaching plan briefly before I let you go. Got a couple minutes. The teaching plan, you have choices. You can choose a client that has a history of substance abuse. And so you just do a brief history, social, medical history, and then you do a brief newborn assessment of the newborn from a substance. So you're thinking neonatal abstinence syndrome. And there's some real hints in chapter 25 of your text talks about neonatal abstinence system. What would you see and what would your interventions be? Okay, so you can do that, or you can do the baby of a diabetic mother, type 1, type 2, or gestational. What would you see with that baby? Your focus is on the newborn. Okay, so with a diabetic baby, a baby of a diabetic mother, you're going to see the respiratory distress and the hypoglycemia. Okay, and a big baby, you might see some birth injuries. Okay, so you could do either one of those, or you can do preterm. Of course, preterm means that you got to go into chapter 25 as well and look at what kinds of concerns that preterms could have. Respiratory distress, of course. Temperature regulation is huge, and in protecting them from infection. Okay. So the teaching plan is not, I don't want to say it that way, but it's only 1% of your homework, okay? But use it as an opportunity to learn about NAS or neonatal abstinence syndrome or a diabetic baby, or learn more about the preterm baby, okay? If you want more help, you can send me a rough draft and I'll let you know what you're missing, okay? So just follow the rubric, okay?
Is this already posted, Professor? 'Cause I saw that it was live.
It should show up. I think next week it shows up, yeah,
Okay.
okay?
And it should have the instructions on how to do it besides the
Yeah,
rubric?
yeah.
Okay.
Yes.
Does it
uh-huh.
also give you like a patient that you kind of follow?
No, you make up your own
Make up
patient.
your own patient. Okay.
This assignment is for next week, right?
Yes. Let me see if I can find it for you so I can show it to you. You're free to go whenever you want to, but I'm going to show it to you. If there's anybody left when I get there.
I'm still here.
You're still here. Okay. Okay.
No, no, no. Es no
¿Qué tú quieres de Pipi?
No, no, no.
Pipi.
Okay. So here it is, the teaching plan. So you can choose from choose one of the three. Like I said, create
Okay.
the mother, make up a social history, make up a medical history, and you must put her her GP status, gravidaparis status. You have to put that in there, and then you're gonna just focus on the newborn. Okay, it says to do a head to toe assessment. I want to see an APGAR, 2 APGARs, and then what you would see on assessment of a newborn. I don't want you to go, abdomen is soft, I can hear bowel sound. You don't need to go into that much detail. Just focus on what you would see based on the mother's history.
Okay.
Is this going to be a PowerPoint or do we just put this on like a Word
You
document?
know what? If you want to do a PowerPoint, you can do a PowerPoint. You can do a
Can you do
video.
Word?
Okay.
You can do a Word document. You can do a video.
1%.
You can do a pamphlet. I don't care how you do it.
Okay.
Just have fun with it.
I might do a
If you can.
pamphlet, Professor.
Yeah, you can do a pamphlet.
All right. Thank you,
You can do
Professor.
a pamphlet as if you're producing it to give to an OB office for any diabetic client or
Mhm.
whatever. Okay, just be creative.
Thank you.
You're welcome. I've
Yeah,
had
thank you.
students in past, you're welcome, draw pictures. And that would be fun for me, so. If you need help, you know, you can let me know.
I did send you a text.
Oh, okay. Okay, thank you, Nicole. I kind of assumed that.
Okay, I was just making
Thank you.
sure.
Yeah, same proctor.
Yes,
Okay, that's fine. Thank you so much.
thank you.
You're being responsible.
Try to keep it consistent.
Yeah, consistency is good, isn't it? Routine, consistency
Yes.
is good.
The one that's like the biggest thing I enjoy.
Yeah, yeah, yeah. Okay, all right.
All right,
Thank you.
you.
Uh-huh, bye-bye.
Bye.
Hi, Leanne.
Hey, I just had a student issue. Oh, did you want to stop recording?
Thank you very much. Did I not stop? Stop sharing. Thank you for noticing.